Please listen carefully.
Hello, Team Anaesthesia. Welcome to GasGasGas. This is the best anaesthetic science podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. Now, you might be in the gym right now, commuting, or ironing your scrubs, and there's no judgment here. GasGasGas will prime your brain for the monsoon of knowledge you need to imbibe. But regardless, the revision is eventually going to end. But for now, expect facts, concepts, model answers, and the odd tangent. Now remember to check out the website, that's gasgasgas.uk. There are show notes there with all the detail, plus links to foundational reference papers and anything else useful I find for you guys. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, and welcome to a return of VivaCast. It's been a long time coming. We've got a number of episodes planned over the coming weeks from a couple of different sessions with people, hence why we've missed one or two episodes of GasGasGas, because we've been sorting this instead. Today is one of probably 4 episodes with a gentleman called Martin, who works in Sweden, particularly Malmo, if I'm pronouncing that right, who is preparing for the EDAIC, which is the European Diploma in Anaesthesia and Intensive Care. He's sat his paper-based exams and he's preparing for his oral examination. So without too much kerfuffle, we're going to get straight into it. And Martin and I just have a couple of quick questions with each other to try and figure out what the crack is before getting on with some pharmacology. So I hope you find it useful, folks. And for those who are about to sit their primary FRCA exams next week, good luck. Think like an anaesthetist.
So where are you at? Geographically as well as career-wise?
Yeah, cool. So I'm in just very slightly south of Yorkshire in the United Kingdom. I'm a anaesthetic registrar, so not yet a consultant in the UK. I finished medical school about 10 years ago now, so I am nearly there. So yeah, it goes on and on and on. But yeah, training in the UK is quite long, I think.
I think we're at quite similar stages then, because I also graduated medical school about 10 years ago, and I've done some different jobs in between, and then finished my specialty training this January.
Ace. Okay. How long?
But we sort of get the title of consultant straight away, I guess. We don't really do. I don't think there's an equivalent to registrar. Yeah, it's a bit different.
How does it work? How does training in Sweden work?
So medical school has changed since I graduated, but when I graduated, it was a 5.5-year education. Then you did a 1.5 years of internship, upon which you're awarded your MD or your medical license. After the internship, you go on into specialty training, which lasts for 5 years, and then you're a specialist. So I guess that would translate to consultant. People put consultant in their CVs once they finish, at least.
Yeah. It's a title that most people understand, isn't it? So whereabouts in Sweden are you working at the moment?
So I'm at the very southern end of Sweden. I'm in Malmö.
Okay, lovely. And have you always worked there?
I'm in Malmö and Lund.
Mm-hmm.
No. So I've been sort of living up the west coast. I don't know if you're familiar at all, or
not completely familiar. No.
But Malmö and Gothenburg are like the big cities on the west coast, and I'm from a city called Halmstad, which is right in between.
Okay.
And that is where I did my internship, and then I've been to Gothenburg, and I spent some time in Åre, which is like a skiing resort in the middle of Sweden.
Okay.
So I did primary care, sort of remote medicine there.
Mm-hmm.
And then I went back to Malmö to do my residency.
Okay, so that was like internship, trip to somewhere with
something in between, and then
I'm sure you weren't doing any skiing because you were terribly busy.
No, yeah, true. No skiing at all. Well, I've been to I did a year, like half a year, a semester abroad during med school.
Where was that?
In Australia.
Oh, lovely. Okay. How does the Australian healthcare system compare to the Swedish healthcare system then?
It's very similar. Like they have like a foundation of government financed public healthcare, and then they have like a public system in parallel.
Mm-hmm.
As do we. I think the British is quite similar too, right? Like you could go public if you.
It's mostly public, with some people choosing to go private, but private generally only really gets you like elective planned interventions and scans. There's very little emergent private funded. The NHS generally deals with like the undifferentiated patient. The private sector just picks easy patients to do easy anaesthetics and surgeries on to.
And then once the complications are out, they go back into the public system.
Yeah. Oh, they're bleeding and they're now on ITU. Back to the NHS.
Yeah, it's your gastric bypass surgery post.
Yeah. When did you do the written exams for the EDAIC?
I did that. Yeah, I did that in September last year.
Mm-hmm. And it went?
So there's like a multiple. Yeah, it went well. Like you get this spreadsheet afterwards with scores for different topics, and like it was fine. Like I did better than the average, and on all topics except neurophysiology.
Okay.
So I've been studying up on that. Been reading up on that. I think I did score a few points for free, so to speak, due to because I'm doing a PhD in parallel with my specialist training. Yeah, and as part of that, there's quite a lot of statistics and research methodology and rigor and stuff like that. So I didn't really study that, but it comes up in the European diploma.
Yeah, which is kryptonite to most doctors.
Yeah.
Yeah, and I don't know if they do scoring where they weight things as more or less difficult, and therefore
I'm not quite sure. Like I heard some rumors about them weighing the scores depending on the candidates, how they fare, like in general, and it sort of swings one way or another depending on how many non-European candidates there are.
Okay, right.
Because there are people from all over the world sitting the written exam at very different levels of training. They sort of do it as an application to go into training.
Oh, okay, right.
Yeah, but I'm not sure. Like they don't disclose that kind of thing. But I know the pass rate for the written part is quite high. Like it's 75-80% of people to take it. Whereas the pass rate for the oral one, which is the one I'm about to sit in 11 days time, I heard somewhere that it's about 50%.
50, yeah.
Yeah, 50, yeah. But I'm not sure if that's representative in Sweden. I think because you can take it like there are centers all over Europe, and I think they just like the 50% number is probably like all centers.
Yeah. So it might skew for centers which have more candidates trying to pick it up from the Asian subcontinents, etc., who might struggle more at an oral exam compared to those more familiar with other healthcare systems. Yeah, a bit like.
I think so.
Yeah. Okay. How much studying do folks tend to do for at the EDAIC?
I think it's very different. Like, I've been doing evenings and weekends for about 3 months or so, and I've taken 2 weeks off to study from like now up until the test, and I think that's sort of representative of how most people do.
Yeah. Okay. I've tried to understand a little bit about where it pitches between the primary and the final FRCA, and
yeah, it's quite hard because I think it's sort of in between. Like from what I've been reading up, and you guys have a lot more. I think there's more specifics to the UK system, such as they would ask you certain numbers from like the national audit programs and stuff like that.
Yeah, they would. Yeah,
like they'd be like tell you about the NAP6 or something like that,
and you just
and then you have a massive topic that doesn't really come up on the European diploma, and that is the electrical safety part.
Oh yeah, okay, yeah.
Like we don't really I haven't seen any questions about that.
So no clinical vignette of the scrub nurse has been electrocuted. What should you do next?
Please don't. But otherwise, I think it sort of sits. I think the oral final FRCA is like slightly harder to pass, right?
I think so. Yeah, it's quite challenging, but all good fun. Okay, cool. And in terms of just so I hope that I'm going to pitch this right for you. In terms of the contents of the podcast, do you think that's been falling at the right level of detail, falling short, or what do you think?
For me, for the European diploma, I think it's the level of detail is slightly higher than what they are asking in the exam.
Okay.
Like you wouldn't be asked to draw a molecule. I've never heard anyone do that. Like maybe Propofol for fun, but I don't think.
Yeah, I think it'd be pretty mean. They certainly used to do it. I think they do it less now. But one of my consultant research colleagues was telling me they'd quickly looked in their pocket before the exam at the various volatile anaesthetic molecules, walked in and they said, "So tell us about the structure of sevoflurane." And they were very fortunate that was still in their memory.
We all like everyone seems to have a story like that. But yeah, I think the podcast is great. Just like it's the way you do it. It's sort of it's a very nice sort of flow to it, or like the because I've had a couple of friends who listen to your podcast say that just the way you speak and the way you structure it is very intuitive. Like it's easy to listen to, and it's sort of
tries to make some logical sense.
True.
That's the goal.
Like the way you structure it. Yeah.
Yeah.
So I've been listening to yours stuff, and I've been listening a lot to Anaesthetic. I bet you know those guys, like you're in the same field, sort of.
Yeah.
And both have been really good, like on the commute.
Yeah, I think you just got to try and squeeze it into your day and hopefully find something that fits with your brain, because I know people think differently, and sometimes people need something very clear. Sometimes people need to hang a story off of knowledge to make it sit in their mind. So thank you for the positive feedback. How do you feel about answering some Viva questions?
Let's go.
We'll go pharmacology first, if that's all right, Martin.
That's perfectly fine.
Yeah, if that's your bag, it's my bag. So how does heparin exert its anticoagulant effect?
So heparin exerts its anticoagulant effect by potentiating the effect of antithrombin 3 specifically, and it does so in a 1,000-fold manner. Antithrombin is an endogenous protein that balances the anticoagulant effect in the body and works by inhibiting thrombin.
And whereabouts is antithrombin synthesized in the body?
Antithrombin is synthesized in the liver and excreted by the liver.
And what coagulation factors are influenced by this upregulation of the antithrombin 3 activity?
So the upregulation of the antithrombin 3 activity leads to inhibition of thrombin, and thrombin is the downstream end stage, so to speak, from both the intrinsic and the extrinsic pathway. That would include factors 2, 5, 7, 10, and 10A, I believe.
I'm just going to dip in here quickly to make sure we're getting these numbers spot on, because they could ask you in the exam. It might be really irritating because it's just remembering a list of numbers, not the most clinically relevant. Unfractionated heparin, exon 2, 9, 10, 11, and 12. Low molecular weight heparin only really acts on factor 10A, hence why we measure factor 10A levels. Also remember, warfarin acts on 10, 9, 7, and 2. Apixaban 10A, that's why there's an XA in the name of the drug. Rivaroxaban, same thing. And dabigatran thrombin inhibition, factor 2. And also remember, 1 milligram of protamine reverses about 100 international units of unfractionated heparin. Anyhow, let's continue listening to what Martin has to say here. Tricks you on, definitely. And say we're now on the ward and patient is bleeding and they've been anticoagulated with unfractionated heparin. What approaches to reversal of that heparin could you take?
So reversal of unfractionated heparin really comes down to either you give a medication with a direct antagonistic effect, that would be protamine, which inhibits the effect of heparin directly, so to speak, or you could reverse the effects of heparin by giving coagulation factors, so that the whole hemostatic picture of the patient trends more towards a thrombogenic one rather than the bleeding one.
Ideal. Could you compare and contrast low molecular weight heparin with unfractionated heparin, please?
Sure. So the unfractionated heparin has a very short onset, like it's very fast onset, and has a very short duration, whereas the low molecular heparins, they do have a longer onset and a longer duration. They are, so the unfractionated heparin are commonly used during cardiac surgery and has the advantage of being easily titratable, and you can measure the unfractionated heparin's effect by activating clotting time. So it's used as a point of care test. For the low molecular weight ones, these are more of a dose twice daily regime, or more of a long-term treatment. You can measure their effects indirectly through activated prothrombin times, but you cannot use the activated clotting time in the same manner. So so I tend to think about it like the unfractionated heparin. That is when the patient is in the OR or just right afterwards, and whereas the low molecular weight ones are more used for a longer duration and for out of hospital dosing as well. So like prophylactics or bridging therapies when you can't use your regular anticoagulants.
And what about the side effect profile of heparins in general?
So heparins in general, for the unfractionated ones, I know they have the feared complication of heparin-induced thrombocytopenia that does not occur with the low molecular weight ones. So that's like the specific issue with the unfractionated heparins. As with all anticoagulants, a risk of using them is bleeding. The unfractionated heparins have a higher risk of bleeding, whereas the low molecular weight ones have a lower risk of bleeding.
Classically, they're more predictable. That's why you can give them and know that you will have a degree of anticoagulation for a certain period of time. What other anticoagulant medications are you familiar with?
So for anticoagulant medications, I want to split these into classes by mechanism of action. So we can start with the vitamin K antagonists, or warfarin. So warfarin is a vitamin K antagonist, and it works by inhibiting the synthesis of vitamin K dependent factors. Do you want me to go into deeper detail on that, or do you want me to keep going for the other ones?
Talk me through the drugs that you're familiar with for anticoagulation. So you've mentioned vitamin K antagonists.
All right. So the vitamin K antagonist. Then there's the direct factor 10 inhibitors. That would be your dabigatran and the likes of those. And then there's your I lost track. Direct thrombin inhibitors, which have a similar profile to the factor 10A inhibitors. And that would be your it's called Pradaxa in Swedish, dabigatran, I think.
Yeah, that's why in the UK it's called dabigatran, but the reversal agent, I think, is Praxbind or something like that.
It's Praxbind, yeah. I think that's the European name for it. And then on the other side of the spectrum, you have your thrombocyte inhibitors, which are they either work on the P2Y12 receptor on the surface of the thrombocyte or on the GP proteins. And then there's your, I guess those are the ones from the top of my head.
Yeah. I suppose if we're going into antiplatelets, then aspirin would probably fall in there as well.
Oh, yeah, true. As an antiplatelet drug, yeah.
And with these slightly more novel agents, the factor 10 inhibitors and the factor 2 inhibitors, what's your approach to reversing them in an acute situation with bleeding?
So if you're in an acute situation where the patient is bleeding, the fastest way of reversing these new oral anticoagulants is still to give plasma concentrate. You can either give fresh frozen plasma or you can give PCC, which is the plasma concentrate. In Sweden, that's called Confidex, thereby giving the factors and outcompeting the drug rather than inhibiting the drug itself. Some of the drugs do have specific antidotes. We mentioned Praxbind, which is I believe it's a monoclonal antibody that neutralizes the dabigatran. I do think there are other monoclonal antibodies as well, but they are not in clinical use where I work. Should you not reach adequate hemostasis with the fresh frozen plasma or the PCC, you could move on to giving more specific factor concentrates, such as Novo-7, which is the factor 7 concentrate. And I believe there are at least a few other specific ones, but I haven't used them myself.
Yeah. And what would your preference do?
And also, like for any bleeding patient, keep them warm, not acidotic, well ventilated, all that kind of stuff. And if it's a surgical bleeding, you will need the surgeons to get a move on.
And what would your preference be, or how would you approach choosing between fresh frozen plasma, a prothrombin concentrate complex? In the UK, it's Octaplas or Beriplex, where you've got all these novel agents. What would your approach be to and weighing up between what you would prefer to use?
So in my hospital, the PCCs would come first. It's on the ward, and it doesn't have to be ordered from the blood bank, whereas the plasma would have to be carried into the OR. So logistically, the PCC would be administered first. I guess that's the practical approach to it.
Okay, ace. And what we'll do is we'll move on to another question. I've got a few notes, we'll debrief, and then we'll pick a different route to go down. Anyhow, time for a brief mention about the sponsors of GasGasGas, Teach Me Anaesthetics. These guys are behind an excellent single best answer question resource. Firstly, I took the joyful, challenging, and intermittent bashing through their 1100 plus questions, which they have written for the FRCA primary exam. Now, I secretly loved it, and there are plenty of questions to test your knowledge. When I was studying for the FRCA primary, it did not exist, but there were other packages online. These cost a lot more, and they didn't really seem to reflect the content of the exams. Whilst doing them, I came across rehashed MRCP questions, which was not terribly inspiring and left me pretty cheesed off. whereas these single best answer questions have been built from the ground up. They have not sniffed an MCQ in a past life. They are based on the anaesthetic science you need to know, and there are explainers with all the questions, so it builds your knowledge as you work through them. There is a multitude of ways you can study these questions. You could choose to do a random battle with 1100 plus questions, or split them into subject area. You can go back and redo the ones you've gotten wrong. It's very malleable. So if you've been thinking about which question resource you might want to get your hands on for the exam, you shouldn't really look any further than Teach Me Anaesthetics. If you reckon it's for you, all the links to Teach Me Anaesthetics from GasGasGas are affiliate links. So if you're signing up through one of those, you're helping to support GasGasGas. So if you think you're going to go for it, click a link with me. You know you want to. You'll not only be supporting your exam preparation, but you'll be supporting your 100% favourite Tell Your Nan Over Sunday Lunch podcast, which is of course GasGasGas. What's the pharmacological fate of a single IV bolus of propofol?
So the pharmacological fate of a single IV bolus of propofol is that the initial injection will raise your plasma concentration fast. Then, due to propofol's lipid solubility, it has a bimodal half-life. So the concentration in plasma will rapidly fall once it is redistributed first to well-perfused organs, hopefully to the organ of effect, and then into less perfused organs. And then the plasma concentration will fall at a slower pace. And this is due to elimination in part, but also redistribution back into the plasma. So there's like a balance between drug coming back into the plasma from the peripheral compartments and actual elimination.
And
so we can talk about sort of the redistribution half-life of propofol, and we can talk about the terminal half-life of propofol.
Go ahead.
So the redistribution of half-life of propofol is fast. That would be in the order of magnitude minutes, whereas the actual terminal half-life is more in the order of hours.
Lovely. And you've used the term half-life there. Could you just talk me through what half-life is?
So a half-life is defined as the amount of time it takes for a concentration to half, so to reach 50%. And the term itself carries an exponentiality to it, because if you have something and then you have it again, the speed with which the concentration is going to fall will be slower.
Absolutely. But then in contrast, what is time constant? Are you familiar with this term?
I believe a time constant is a slower process than a half-life, and I believe the relationship between the time constant and a half-life is that a time constant is 4 half-lives. I might have gotten this wrong.
Yeah, we can come back to it in a jiffy.
Thank you.
We've discussed the redistribution fate of propofol. How is propofol metabolized and cleared from the body?
So propofol undergoes hepatic metabolization into non-active metabolites that are renally secreted.
And in your practice, are you infusing propofol? Are you doing total intravenous anesthesia?
Absolutely. We do both total intravenous anesthesia and gaseous anesthesia with propofol induction.
And what are you utilizing any pharmacokinetic models with your total intravenous anesthesia, or is it infusion rate based to body weight?
We can do both. Where I'm at, we do infusion rate based in pediatric patients. We do infusion rate based if the patient is undergoing sedation rather than induction for general anesthesia. Otherwise, we have just recently, like within the last 6 months or something like that, moved from the Marsh and Schneider models to the Eleveld model for target controlled infusion.
Yeah. What are the key differences between the earlier Marsh and Schneider models and the newer Eleveld model?
So the Eleveld model takes into account more variables than the Marsh and Schneider does. The Eleveld model takes into account height, weight, and age of the patient, whereas it also scales allometrically, which means that it doesn't just scale linearly. So it sort of takes into account age and how should I put this, metabolic status of the patient in a way. I have seen the full algorithm once, but I could not write that down for you. But
that seems eminently reasonable. Yeah. Just as an aside, how have you found the change to the Eleveld model? Have you noticed anything in particular? Patients being lighter, deeper compared to what you'd expect with the other model?
I believe I have noticed that the Eleveld model sort of gives a bigger bolus hours, and then has you sit without with a zero infusion rate for some time. So it puts a greater demand on the anaesthetist patients when it comes to waiting out the effect, but it does provide greater hemodynamic stability.
Okay, lovely. So let's just swing slightly towards non-target controlled infusions, mils per hour infusions on intensive care. What do you understand about propofol infusion syndrome?
So propofol infusion syndrome can occur if the duration of propofol sedation or anesthesia is prolonged and with a high infusion rate. So the infusion rate normally cited is 4 milligrams per kilo at a duration of, I believe, more than 48 hours. That is when you could start seeing propofol-related infusion syndrome. So PRIS is a clinical syndrome of hemodynamic instability together with findings such as a green-tinged urine and hypertriglyceridemia, I believe. The reasons for the propofol-related infusion syndrome, like the pathophysiological basis, I do not believe it's quite alluded to.
Yeah, I think
I believe it's unknown.
I think there's some suggestions that it's mucking around with the mitochondria, but I don't think there's any robust. We definitely know the pathophysiology of this.
I've seen someone cite it as a direct cardio depressant effect, but I've always thought of propofol as having indirect cardiac effects with the vasodilatory issues rather than. I'm not sure if it's certain.
And how would you treat propofol infusion syndrome?
I'd start by so I'm at the ICU bed, and I believe my patient has starting to get propofol related infusion syndrome. I would start by declaring an emergency. I would call for help. I would stop the propofol infusion. However, still making sure that my patient has some sort of hypnotic going, such as I could give bolus doses of midazolam, which is very cardio stable. I would give bolus IV crystalloids to combat the low blood pressure, and otherwise I believe it's a supportive treatment only.
Fix what you can fix and let time take its course. Yeah, definitely. Cool. Okay, that's me. Got to the end of my little conversational journey. How do you feel?
I sort of have. I think it's hard to know what level of detail you should aim for. Like when you asked for the oral anticoagulants, should I just list them all first, or should I start by explaining warfarin in detail and then maybe not have time to say that I actually know a few more? It's hard to sort of. I guess it comes down to time disposition. How do I use my time appropriately?
Yeah, reading the body language of the examiner is half the battle, because if they're if they've taken a bit of a breath and their eyebrows raised, then perhaps you're going slightly off piste. But definitely always answer the question that they've asked you, but always make sure to think broadly, because sometimes, particularly in for the FRCA, there might be a really obvious answer to the question, tell us about drugs that impair neuromuscular function, and you say, oh well, here's succinylmethonium and rocuronium, etc. But actually, large doses of magnesium, gentamicin, botulinum toxin, all drugs that affect the neuromuscular junction. So just always be slightly cognizant. If they're asking you a question that sounds really simple, just think, do I need to take a step back and demonstrate my structure is also really broad and simple when I'm approaching a floppy patient in A&E versus a floppy patient in recovery, because they're still paralyzed. And then, always pile in with a classification, or at least that's what's recommended if there is some sort of structure, which you certainly did with the anticoagulant question when we spoke about other anticoagulants. Some people might say that antiplatelet agents aren't technically anticoagulants, but you could jump in with anticoagulant agents that I know of include vitamin K antagonists, direct thrombin inhibitors, and factor 10A inhibitors. These can be, warfarin, coumarin, or whatever it is, dabigatran and apixaban, rivaroxaban. Some people also include antiplatelets in this, which would break down into the PY12 ADP receptor antagonists, clopidogrel, ticagrelor, or prasugrel. I don't know if what's the common one in.
Yeah, it's the same. Yeah. Brilic, I believe it's ticagrelor. It's called Brilic.
Yeah, we're not allowed to use brand names because it's the NHS. Because if they say, we don't need to know about antiplatelets, actually, then they'll move you on. And but it's demonstrated that you're thinking broadly and you've got structure and you're giving them a chance. They might say, well, tell us more about apixaban or et cetera, et cetera. So let them take you on a journey.
It's going to be hard for the European diploma this year because they have just switched from examiners in person to examiners online.
Have they? Interesting.
So as candidates, we travel to. So for me, I'm going to Uppsala, and we're going to be there in person, but the examiners are going to be there via some sort of video link. Yeah,
you're talking to a robot. Hello. Yeah. How do you feel about that?
I find it hard. Like it's a lot harder to read someone through this medium, so to speak. I think my strength is that I can. I do not have an issue talking. I believe. I don't think because I've heard some people failing the exam due to loss of words, like just stressed out. Whereas I don't think I will have that problem, but I do not know how it's going to feel when the examiner is on a link.
Yeah, I suppose it probably absolves you of having a bit of paper and then being like, so write down this formula, because are you going to write down a formula and then
I have no idea how that's going to and hold it up?
Throw it to a screen? Probably not. So they'll probably have to design questions that avoid that, which is probably beneficial because then you're asked to probably describe the relationships more as opposed to draw a diagram that demonstrates relationships.
And label graphs and label axes.
So we've covered the anticoagulation side of things and antiplatelets. We've compared and contrasted unfractionated versus low molecular weight heparin. But I did make an assumption that those were two drugs that were in use in Sweden. It's just I'm making
Oh, they are absolutely. Yeah. It's just I think it's the same as in the UK, right? Like the unfractionated ones for the OR and for
So in the UK we would use unfractionated heparin, cardiac surgery, vascular surgery, for managing an acute thrombus in someone who might need to go to theatre, whereby, say for example, someone has an acutely ischemic limb, they need to go to theatre, but for some reason it's going to take an hour or two, then you'd start them on an unfractionated heparin infusion, or post-operatively run them on that infusion. The other way to treat, an excessive degree of anticoagulation is just stop the infusion and wait 4 hours. But in a bleeding patient, rightly, are you going to just keep putting blood in, waiting 4 hours, or are you going to do something about it?
Yeah.
Have you ever mixed protamine and heparin in an ampule?
Like both in the same? No.
Yeah.
It precipitates, does it?
It's just white. It just turns into something that looks like propofol really quickly. It's amazing. It's cool.
Whoa.
And side effects of heparin. So you bagged the two critical ones of bleeding and heparin-induced thrombocytopenia. We call it HIT in the UK. I'm sure you call it HIT as well.
Yeah.
But you could probably say some other things as well. For extra points would be hypersensitivity reactions. So some people are weirdly allergic. Allergies are always a fair game to say in a side effect. And then particularly for heparin, it can drop blood pressure, can cause hypotension. And then in prolonged administration, it can lead to hyperkalemia, osteoporosis, and alopecia. But those are, that's like niche stuff. Bagging.
How prolonged would that be? Like if you're on it for weeks on end?
This is probably going to be weeks on end. The hyperkalemia is greater than 7 days, is what I've got written down here. But I imagine if you're someone who's had a PE and you're on long-term anticoagulation and for some inexplicable reason heparin is your only choice, then you might find yourself being in that small patient group exposed to heparin long enough for it to cause those sorts of complications. Probably more of an issue before we had all these other fancy drugs. And you can get hit with low molecular weight heparin, but it is far, 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 far rarer than unfractionated heparin. Unfractionated ones are where you do see it. And you could probably, I can't remember the differentiator, but there's two types of hit. I think one of them is like not really too much of a bother, and that's the one that happens with low molecular weight heparin. And then the florid, oh my God, their platelets are 3.5.
That's the IgE mediated one, is it?
Yeah, I think so. Yeah, the type 2 immune mediated. Leading to venous or arterial thrombosis, generally bad for your health. And then propofol question. And I don't know in the EDAIC, you probably know this more than me. Do they have to keep you talking for the time frame? So they would just ask you another question, ask you another.
Yeah. So the time frame is very strict. Like they would keep you going. You're not allowed to be quiet because they only have. So it's 4 interviews, and for each interview there are 2 examiners speaking for 12.5 minutes each. So it's 25 minutes times 4 the whole examination.
Okay, and they keep you chatting. So nice clear answer with what happens to a dose of propofol. In the exam, they might want you to start talking about that multi-compartmental model in greater detail. They might want you to start drawing out that formula, but it sounds like with the structure of the exam that it would be pretty mean to ask you to try and describe that formula that describes the multi-compartments. We touched on half-life and time constant. Definition of half-life was good.
Yes, please. The time constant was not correct, was it?
Yeah, so time constant is the rate of clearance or elimination from a system if the initial rate of change remained the same. So if you imagine that graph, that acute steep bit, that is the time constant. The time constant is, let me get this right.
Because there's a number, right, where the time constant is X amount of half.
Yeah, it's a rate. Yeah, so a time constant. So the half-life is about 70% of the time constant. And in that multi-compartmental model graph, where you sort of see a particular rate of change and then a slower rate of change and then a slower rate of change again, if you were to take tangents off those lines, they're time constants for the clearance into each of the different compartments within the system, so to speak, those tangents. So, Tim, for blistering clarity, half-life is equal to 0.693 times the time constant. This time constant is more rapid than half-life because it reflects the rate of change if the initial rate of change in that system is maintained, the time it takes to hit zero. The masterpass definition is really clear. That is, time constant is the time it would take the plasma concentration to reach zero had the original rate of change continued. It is the reciprocal of the elimination rate constant, the opposite, and it can be read directly from a concentration time curve.
I think the number I told you, I think I confused it with the time it takes to reach steady state.
That's 4 to 5 half-lives is what they would generally quote, or 4.5 I think is like, but I just say 4 to 5. Yeah, cool. And then propofol infusion syndrome. I don't know if we touched on what defines the syndrome completely. You mentioned hypotension and the urine going green. What will happen is you get a metabolic acidosis, rhabdomyolysis, and a hyperkalemia. And the rhabdo causes renal failure and, as you mentioned, cardiac dysfunction. And yeah, the treatment, as you said, it's supportive. It's stop the propofol. You could think that what are other complications that come from a high lipid burden, because I think that's what they're suggesting. It's not necessarily, I don't know if it's the drug or the lipid burden that's causing the problem. Pancreatitis would be the one people get when they've got hypertriglyceridemia, like you said. Do you think that was about the right level-ish?
Yeah. I think the level, I think that was similar to the sort of mock exams I've done before, as if I've made a fool of myself.
Oh no, absolutely not. No, it's a very genuine experience.
I think my standards for that are very, very high. So
yeah, I can think of 1 or 2 moments where I felt like 11. Ace. Well, I mean, thank you very much for taking the time as well, Martin, because you're one of the first people who's actually had the guts to come on and accept the experience, so to speak, after Tom. But yeah, so thank you very much for being the first victim.
It's going to be so much fun to hear the episodes. It's, yeah,
absolutely. You're going to be famous, Martin. There's going to be at least 100 people will have heard your voice.
It's perfect. It's so great, James. Thank you so much, and have a lovely evening. We'll catch up, I guess.
Yeah, you too. Have a nice afternoon. Take care. Well, everyone, that was the exceedingly calm, cool, and collected Martin from Malmö in Sweden. He's getting ready for his EDAIC exam. I wish him all the best, and there's a few more sessions to come featuring Martin's slick approach to answering these Viva-flavoured questions over the coming weeks. So thank you very much to Martin. Thank you all for listening, and I'll see you next time. Cheers. Ahoy, Team Anaesthesia! You've survived yet another episode of Gas, Gas, Gas. Now, if you found it useful or harrowingly awful, please like and subscribe, drop us a star or 12, and follow with whichever podcast platform you find yourself using. Please leave a comment or ping off an email if you think I need to square something away. Now, there are a bunch of ways to support the costs of Gas, Gas, Gas. From buying me a coffee, to venturing forth via an affiliate link, to the horde of joyful SBA questions from Teach Me Anaesthetics. Those links are on the website and in the show notes. Speaking of website, definitely check out gasgasgas.uk for the show notes, diagrams, details, the references. Now, we all know, guys, that this is a bucket of content to consume, and it is like drinking from a fire hose. So I want to finish by saying, take it day by day, don't overcook yourself, don't freak out, and keep studying.